Welcome to the Endocrine Matters podcast. This podcast episode is sponsored by Complete Medicine and Hey Healthy. Welcome back to Endocrine Matters, the place where we challenge conventional thinking, elevate women's health, and talk honestly about the endocrine system and the U.S. healthcare model that too often fails women. Today, we are diving into a topic that impacts every woman fortunate enough to live long enough: perimenopause and menopause. This transition is universal, and yet many women are never taught what it really means for their bodies, their minds, and their long-term health. Many clinicians are not trained to manage it well, and a lot of the public information out there is either incomplete or just plain wrong. We're going to change that today. I'm going to walk you through what perimenopause actually is, why this transition affects every organ system in the body, the most common myths about hormone therapy, and how to build a science-based, empowered approach to your menopausal health. Let's get started. So, what happens in perimenopause and menopause? Menopause is a natural biological transition, as natural as puberty, but far less talked about. Perimenopause is the phase leading up to menopause when hormone levels become unpredictable. You may have cycles with extremely high estrogen followed by cycles with very low estrogen. These fluctuations are the hallmark of perimenopause. Menopause itself is defined as 12 consecutive months with no menstrual period. After that point, the ovaries dramatically decrease estrogen and progesterone production. Perimenopause technically lasts 1 year after menopause. So here's the key. Estrogen receptors exist throughout your entire body, so changes in estrogen can affect your brain, mood, sleep, bones, metabolism, skin, cardiovascular system, muscles, immune function, pelvic floor, and bladder. This is why there are over 37 recognized symptoms of perimenopause and menopause. This is a whole body transition, not just hot flashes. Common symptoms include hot flashes and night sweats, brain fog, changes in mood or anxiety, difficulty sleeping, weight gain, especially around the middle, loss of libido, vaginal dryness, joint pain, palpitations, increased urinary urgency or frequency. And here's another truth that surprises many women. Symptoms can last 4 to 14 years, not just a few months, not just a year or two. This is a major phase of life, and women deserve support through it. So why is every woman's experience different? Your perimenopause will not look like your friends, your mothers, or your sisters. Hormone fluctuations vary dramatically from woman to woman. Some women have sky-high estrogen for months at a time. Others plunge downward quickly. Genetics, stress, lifestyle, body composition, and overall health all play a role. There's no single normal way to experience menopause, and that's why personalized care is so important. You deserve a clinician who listens to your symptoms, understands how hormones affect the whole body, and tailors treatment to your goals and history. Okay, my top 10 biggest myths about menopause and hormone therapy. 1, there's only one kind of hormone therapy. The reality is there are many formulations today. Patches, gels, oral tablets, vaginal preparations, and several contain molecules identical to the hormones produced naturally by your ovaries. My favorite approach for most women is a bioidentical estrogen patch and oral micronized progesterone when needed. These tend to be well-tolerated, effective, most often covered by insurance, also not that expensive if you're not using insurance, and they're widely available at your regular pharmacies. Myth number 2, compounded bioidentical hormones are safer. The reality is there are FDA-approved bioidentical options that undergo strict safety and quality testing. Compounded hormones, while sometimes necessary for special cases, are not held to the same quality standards and may vary in dose or purity. For most women, FDA-approved bioidentical estradiol and progesterone are the safest, most consistent options. Myth number 3, hormone therapy increases the risk of heart disease. Reality? This belief came from early interpretations of the Women's Health Initiative study, or WHI, but later analysis made something very clear. The average woman in that study was 63 years old, many years beyond menopause, and starting hormone therapy at that stage carries different risks. When hormone therapy is started within 10 years of menopause or before age 60, the overall risk-benefit profile is much more favorable. For many women, hormone therapy started in this window is associated with reduced all-cause mortality, reduced risk of heart disease, improved metabolic markers. So context really does matter, and timing matters, and age matters. Myth number 4, estrogen causes breast cancer. The reality is that this is the most widespread myth, and it's simply not supported by the data. Here's what large trials have shown. Women who took estrogen alone actually had lower rates of breast cancer compared to placebo. The combination of estrogen plus certain synthetic progestins showed a small increase in risk with long-term use. More modern regimens using micronized progesterone appear to have a more favorable risk profile. No increased breast cancer risk was observed in the first 5 years of therapy. The relationship between hormones and breast cancer is nuanced, but the idea that estrogen universally causes breast cancer is not supported by the evidence. Myth number 5, hormones are the only effective treatment. Some women don't want to be on hormones, and that's understandable. And the reality is that there are many effective non-hormonal options, including certain antidepressants like SSRIs or SNRIs in some cases, gabapentin, clonidine, a newer medication class that targets hot flashes through the brain's thermoregulatory center. Lifestyle strategies can be very effective. Cognitive behavioral therapy. Hormone therapy is one tool, not the only tool. It is a tool that many women have not been offered, so I'm glad that it is being discussed more openly now, but it is not the best option for every woman. Myth number 6, women with early menopause should avoid hormones. This is so wrong. The reality is that women who enter menopause early, before age 40 or even before age 45, lose years of protective estrogen. Without it, they have higher risk of many, many things like heart disease, osteoporosis, even perhaps cognitive decline and mood disorders. In these cases, hormone therapy is typically considered hormone replacement. It's not symptom management and is usually recommended until the typical age of natural menopause. Myth number 7, only severe symptoms deserve treatment. In reality, if your symptoms, even mild or moderate ones, affect your daily life, your work, your relationships, or your sense of well-being, you deserve treatment. We should not dismiss those symptoms. And remember, some changes of menopause are silent, like bone loss or increasing cardiometabolic risk. Even if hot flashes aren't severe, your long-term health still deserves attention. Myth number 8, symptoms only last a short time. We wish, right? The reality is, for many women, they last several years to more than a decade. That's a huge portion of a woman's life, and often during her busiest years. You're not supposed to just power through that without support. Myth number 9, if I don't have symptoms, I'm done with menopause. The reality, menopause is a lifelong hormonal state. Symptoms may come and go, but the physiologic effects continue, especially on bones, brain, and cardiovascular health. Myth number 10, lifestyle doesn't make a difference. The reality is that lifestyle is medicine. Quality sleep, consistent strength training, good nutrition, stress management, and building muscle mass can dramatically improve symptoms and long-term health. Women deserve access to treatment and lifestyle support, not one or the other. Bonus myth, it's all downhill after menopause. The reality is this is absolutely false. Many women feel a sense of freedom and renewed clarity post-menopause. With appropriate support, women often feel stronger, more confident, and more centered than ever. Menopause can be a powerful new chapter, and it's not an ending. So let's talk about weight gain in menopause and GLP-1 medications. Let's shift to something many women notice in midlife, weight changes, especially around the midsection. This is not your imagination, and it's not a lack of discipline. Declining estrogen affects how your body stores fat, your metabolic rate, insulin sensitivity, appetite regulation. GLP-1 medications like semaglutide and tirzepatide can be helpful tools for the right women. These medications mimic a natural hormone that helps regulate fullness, blood sugar, and digestion. Benefits may include reduced visceral fat, lower inflammation, improved glucose control, less food noise, that's thoughts around food, steadier appetite. But here's the key: medication alone isn't enough. Diet and exercise matter. They support the medications and help you get stronger and healthier while losing weight. So don't think just GLP-1 medication, think GLP-1 plus protein plus 0.7 grams per pound of protein per day, plus strength training at least 2 to 3 times a week. This combo helps women lose fat while protecting strength, bone, and metabolic health. Here's the truth I want every woman to walk away with. Menopause is inevitable. Suffering is not. Your symptoms deserve attention, your quality of life matters, and you are not supposed to figure this out alone. If this episode resonated with you, please share it with another woman. We need to change the culture around menopause, and that starts with informed conversations. Follow me on Instagram at Dr. Arti Thangudu for daily education, and subscribe to Endocrine Matters on your favorite podcast platform for more science-backed empowering episodes. Thank you for being here, and remember, you deserve to feel your best at every stage of life. I'll see you next time.